Good evening, all the respected dignitaries and dear delegates. We are having a good number of 41 people now. I'm really happy to see that. And welcome to Journal Journey of Maha IIP and Raigad IIP. Today is Mahatma Gandhi Jayanti and our beloved Prime Minister, late Lal Bahadur Shastri ji, and we bow in their memory and immense contribution to the development of India. Also, recently concluded our Ganesh festival. But Ganesh ji remains in our heart, and Bappa gives us very good knowledge. He is a God of knowledge, and our journal journey strives to the spread of knowledge to practicing pediatricians. For further proceedings of today, may I invite young, dynamic Vice President of Raigad AHA, Dr. Swati Likhite.
Thank you, dear madam. Thank you, dear Chitra madam, for the kind words. Good evening, one and all. Once again, myself, Dr. Swati Likhite, welcome each one for today's journal journey. Today, we have two important topics for discussion: association of preterm birth and lower academic attainment and urinary tract infection. We have two very excellent speakers and two excellent experts. And I'm sure both the sessions are going to be very valuable to all of us. Before we start, I would like to invite our Women's Forum co-chairperson, Dr. Neha Singh, to welcome our guests. Over to Dr. Neha.
Thank you, Dr. Swati ma'am. Good evening all. I welcome all the respected dignitaries, seniors and friends who have joined us through Zoom as well as YouTube Live. For today's session, I welcome our Maha IIP President and Executive Board Member of Central IIP, Dr. Ramakant Patil sir, Secretary General Maha IIP, Dr. Amol Pawar sir, Vice President Shyam Chaudhary sir, and other EBs of Central IIP, Dr. Jitendra Gawane sir, Dr. Renu Goralkar ma'am. I also welcome Raigad IIP President Dr. Vikas Mohan sir, Secretary Dr. Ajay Kohli sir, Dr. Chitra Kulkarni ma'am, and Jay Bhandarkar sir, and other members. I welcome other office bearers of Maha IIP city and district branches, and I'm extremely delighted to welcome our guest of honor, Dr. Vasant Khalatkar sir, for today's journal journey. I welcome the experts of today, Dr. Pankaj Deshpande sir and Dr. Samir Dalwai sir, and the speakers and presenters of today, Dr. Dinesh and Dr. Parvesh Sheikh sir. Now, I request our Maha IIP President, Dr. Ramakant Patil sir, to please give his blessings. Over to you, sir.
Thank you, Neha. We academicians definitely have thirst and quest for the academics and newer insights. And this thirst and quest for academics and newer insight is being fulfilled by Raigad IIP along with the Maha IIP. And I cannot express my enough gratitude to Dr. Nimen, Dr. Chitra Kulkarni, Raigad IIP officials, Dr. Vikas, Dr. Ajay. And it is a wonderful journey along with Dr. Neha that this journal journey is having for last 2.5 years. And has been adding to a more feather to Maha IIP's academic curriculum and academic programs. Friends, we are improving and are becoming bounding again and again and well felt by all various academic activities and particularly by journal journey. And as Neha has already welcomed our guest of honor, Dr. Vasant, and I have a great feeling that a brilliant person and CIIP Treasurer Dr. Samir is with me. We bring greetings from CIIP as an EB member and our treasurer and who is a veteran in CIIP. And we are sharing this screen today together. Thanks to Dr. Samir Bhai's all gadgetry experiences. And we are in Puri now, and we both had we're looking forward to join together. And for this, we have got great stalwart along with Dr. Samir Dalwai sir and Dr. Pankaj Deshpande sir. These are great in their fields and they are great human beings and friends also. And I really like to congratulate Dr. Parvesh Sheikh and Dr. Dinesh. Both Dinesh is a young dynamic academician and special interest in adolescent medicine and developmental medicine. And Dr. Parvesh Sheikh sir, they will be presenting their articles. And I know Dr. Dinesh must have gone to the details and depths about the clinical relevance and day-to-day practice orientation of these topics. With not taking too much time of yours and with such a this preamble, I hand it over back to Neha. And Swati, thank you for being there.
Yeah. Thank you, sir.
Thank you
Thank
so
you.
much, sir.
Yeah.
I hand over to Dr. Swati. Over to you.
Thank you so much, sir, for your blessings, and your words of encouragement are always inspiring the young pediatricians. Now, proceeding further, I invite Maha IIP Secretary, Dr. Amol Pawar, to give his blessings, and also welcome our today's guest of honor, Dr. Vasant Khalatkar, sir.
Thank you, Swati ma'am. And I, from Team Maha IIP, I welcome all the dignitaries, all the experts of today's journal journey, then both the speakers, all the CIIP executive body members, treasurer Dr. Samir Dalwai sir, then guest of honor Dr. Vasant sir, then Nimen Monti sir, the stalwart in this field and who has been guiding us since last 2 to 3 years. And it was nice initiative of Maha IIP and Raigad IIP to start this program in collaboration last year, and this year also we have continued, and I think it will continue forever under Nimen Monti sir's and Chitra ma'am's guidance. So without further delay, I welcome Dr. Vasant Khalatkar sir. He was past president of past chairperson of AOPN, that is Academy of Pediatric Neurology. Then he is current chairperson of ID chapter. He has done his MD, he is fellow of IIP, then he is fellow guide of diploma in child health. Then he was organizing chairperson at Pedicon 2018, which was held in Nagpur. He was past president of COMHAD. He has various publications and he is very active person. And this year, he will be our president-elect for 2024. This is for sure. And I appeal all members who have joined to this webinar from Maharashtra as well as across India to vote for him. The already announcement has been done. And I appeal all Maha-IIPians to appeal all your friends across Central IIP, means other states also, to vote for him. And I now request Dr. Vasant Khalatkar sir to have some words with us. Over to you, Vasant sir. Sir, unmute kara. Sir, unmute kara.
Sir, please unmute.
Yeah. Good evening, all Maha IIP people and today's delegate. Really, I got humbled because of words by Dr. Amol and all Maha IIPian. Not only that, about my degree and about my CV, but really, I think now time has come that every Maharashtrian feel that there should be a president-elect from Maharashtra. I really want to thank. And again, I am requesting you to be there with all get together and come forward. I think elections are going to start on 27th and now election fever is started. First, I want to congratulate all Maha IIP team for journal journey. This is a really new venture and really definitely different. So, after college days, we are again enjoying this Chitra madam, and we were all this in Nagpur. We were doing all these journal journey, that to be once in a month, but now it's really good. Again, we are going to student days, and again, thanks for making me this as a guest of honor. And again, I want to request you to vote. First thing, you make every person from Maharashtra to vote. Then only victory will be ours. I'm confident this time because of your all supports and this everything. Maharashtra is going to win. This victory will not be of mine. This victory will be of you all, and victory of Maharashtra. Thank you once again. And once again, I request you to support my candidature for the post of President-elect. Thank you.
Thank you. Thank you, Vasant sir. Today we also have our dynamic executive board member, Dr. Jitendra Gawane sir, who has just landed in Puri, and I request him to have a few words with us. Jitu sir, please.
Thank you, Amol, for noticing my presence here. I just landed in Puri to represent Maharashtra and joining Ramakant Patil sir and Samir Dalwai bhai for representing Maharashtra's issues to the Central IIP meeting. And this journal journey has started by Niman Monti sir and IIT Raigad, and I have closely witnessed its journey and reaching to the pinnacle of popularity amongst everyone on 1st of every month. So I wish best luck to the presenters, Parvez bhai, and the other topic from developmental pediatrics. So topics are well chosen every time, this time also. And simple topic as UTI will be looking very horrible and horrific if we listen to carefully and not to ignore the basic UTI also. And Pankaj Deshpande sir will make us feel that way, that UTI also should not be taken lightly. So I wish everyone happy learning, and I wish Vasant sir all the best for future journey. Thank you.
Thank you so much, sir, for sharing your thoughts. Now I invite Coordinator Dr. Jay Bhandarkar sir to introduce our first expert.
A minute, Dr. Swati, Dr. Vikas More is remaining. He has joined, Dr. Vikas, our Raigad IIP president.
Okay. Now I invite our Raigad IIP president, Dr. Vikas More, to welcome the dignitaries.
Thank you so much, Swati madam, for giving me this honor. And I am so delighted to see such a galaxy of various academicians and seniors to this very beautiful and initiative taken by IIP Raigad 1.5 years back by our respected Niman Monti sir and Chitra madam, and now along with Jay Bhandarkar sir. So this tree has grown like anything, and now I get appreciation from all over Maharashtra whenever I meet. IIP Raigad is always at the forefront whenever there is some academic activity. When I was in Udaipur just few days back, Ramakant Patil was appreciating IIP Raigad that it is really an active branch, and your branch is really doing good. So my answer was, I don't have to tell my members that you do this and you do that. I am so much fortunate to have such a people in my team that they do these things voluntarily, and I get the credit. So I'm so much proud of my team that and being a part of IIP Raigad. So today we selected two very important topics: the relation between low birth weight and academics, and the simple topic like UTI, if it ignored, can turn into a very serious case. And we are having very good like presenters like Dr. Dinesh and Dr. Parvez, along with the experts like Dr. Samir Dalwai sir and Pankaj Deshpande will be guiding us for clarifying all our concepts. So, and at the end, I'm very much grateful that Ramakant Patil sir, Kallatkar sir, Samir Dalwai sir, Pankaj Deshpande sir, Bela Verma madam also joined. And really thankful that everybody is giving so much appreciation, and they are participating in this initiative. Initially by IIP Raigad, now has been taken up by MAHAIP. Thank you so much. Over to you, Dr. Swati madam.
Thank you so much, Dr. Vikas. And now I invite Coordinator Dr. Jay Bhandarkar sir to introduce our first expert, dynamic Dr. Samir Dalwai sir, and then our first speaker, Dr. Dinesh Saroj. Over to sir.
Thank you, Swati. at the outside, actually, we should not. I actually congratulate or thanks to Chitra Kulkarni madam for carrying out almost 2.5 years. We started on the Doctor's Day. Myself, Dr. Ganguly, first we called Dr. Mohanty sir for the Journey Journal because I'm personally very fond of the Journey Journal thing because we chose a topic which is particular, which is already, I think, will be present in the journal, but at a length discussion with proper study, then you get very important topics. Today's topics are very important, preterm and its outcome, and as well as this UTI. So I again congratulate our own team for choosing these wonderful topics, and I will be very glad and privileged to introduce our first expert, Dr. Samir Dalwai. Is good friend of mine, and is I can say that it's a very expert in development and behavioral pediatrician, practicing same. He is a recipient of Rajiv Gandhi Manav Seva Award and National Trainer for IP 22-23, National Secretary 2021, Executive Board 2018-19. He was the president of IP Mumbai 2016-17, and he's the founder of the New Horizon Child Development Center Foundation New Horizon online intervention programs. So, and he's a consultant in various hospitals like in Nanavati. So I welcome Dr. Samir, as well as he's a chairperson of the IIP chapter Neurodevelopment Pediatrics 2014-15. So thanks, Swati, for this opportunity to talk in this August gathering. Should I introduce
Yes.
Dinesh also?
Yes.
So is our
Yes.
presentation, Dr. Dinesh Saroj is a fellowship in learning disability neurodevelopment pediatrics from Sion Hospital, Mumbai. Founder and director of Development Behavioral Pediatrician, Proud Child Development Center, Nagpur, and has had many publications. As organized secretary for annual conference of IIP Nagpur. As a faculty for CPAP, CIP workshops on development and NAPICON. And his other position is the secretary of AHA, this Nagpur 23-24, past EB member of Maharashtra IIP. So I welcome Dr. Dinesh and congratulate her. All the best wishes for this presenting this important topic. Thank you.
Over to Dr. Dinesh.
Yes, madam. Thank
Yeah,
you.
please start your presentation.
Yes. At the outset, very good evening to all the dignitaries and office bearers of Central IIP, Maharashtra IIP, IIP Raigad, AHA Raigad. Very thanks to Dr. Jay Bhandarkar sir for the kind introduction. And very thanks to Dr. Niman Mohanty sir, Chitra Kulkarni madam, and Dr. Swati Likhite madam for coordinating with me for this for today's activity. I seek permission to share my screen. Title of the article allocated to me is Preterm Birth is associated with lower academic attainment at the age of 12 years, a matched cohort study by linkage of population-based datasets. Authors are all from Netherlands. This article got published in the Journal of Pediatrics in very recently, only 8 months back in December 2022. Its impact factor is 6. And this impact factor had been updated only recently in 2023. The background: despite ongoing improvement in the management of extremely preterm infants, there is a recognized increased risk of subsequent disability. As we all know, a large body of research has been always been indicating that very preterm born infants are at increased risk of adverse long-term outcome. And the academic attainment is the parameter which provides an important measure of long-term outcome of very preterm children, because it has substantial causal effects on health and opportunities in life. The aim of this study was to assess academic attainment, including special education, at the end of elementary school in preterm children born below 30 weeks of gestation in comparison with that of matched term-born peers. The second aim was to evaluate the academic attainment measures within the group of preterm children to detect potential gestational age-related gradients. So simply, the first aim was to compare the need of special education between preterm born kids versus the term-born peers. And simply the second aim was to compare the factors or the parameters which would govern the academic attainment amongst those preterm kids. The place of study was Netherlands. Study design, population-based cohort study. Inclusion criteria, all preterm surviving children born between 25 and 29 completed weeks of gestation between January 1st, 2000 and December 31st, 2007. For comparison, all the term survivors born at 40 completed weeks of gestation in the same study period were included. Exclusion criteria, all infants with congenital malformations. Methodology, the Netherlands Perinatal Registry was utilized to gather the variables that were used for matching the two groups of kids, and the variables were gestational age, birth weight, sex, parity, maternal age, socioeconomic status, and ethnicity. These are the variables used for matching the two groups of kids. Education data was extracted from Statistics Netherlands. Statistics Netherlands plays the role of a third trusted party for data linkage in Netherlands, and it performs the linkage between the perinatal registry and the data from the Statistics Netherlands regarding education. Basically, all children with learning, behavioral, sensory, or physical disabilities that require special education are annually registered at Netherlands in a national compulsory register. Special education was defined as an educational setting in an separate school designed to accommodate educational, behavioral, or medical needs of children who could not be adequately addressed in a regular school environment. Approximately 2/3 of the elementary school use this standardized nationwide academic attainment test that gets conducted at the age of 12 years. So the 5 outcome measures were gathered from Statistics Netherlands were special education participation, the total score out of this nationwide academic test, language score out of this test, mathematics score, and based on the total score, the personalized advice for the level of secondary school. Some word about academic attainment test I would like to mention over here is, it is administered in schools on 3 consecutive days in the final year of elementary schooling, that is at the end of 12 years. And it consists of around 240 multiple choice questions that evaluates different intellectual skills. Further, during the research, the need for special education was determined amongst both the groups at the age of 12 years. Secondly, all kids who had registered outcome measures were matched based on their variables. This matching between the two groups based on all variables was done with the help of these variables like year of birth, month of birth, sex, parity, socioeconomic status, and maternal age. Before matching, the need for special education was determined using chi-square test, and after matching, the baseline characteristics of very preterm children were compared amongst themselves using student t-test for continuous variables and chi-square test for categorical variables. For the first aim, all the 5 outcome variables of academic attainment were compared in between the two groups using student t-test or chi-square test. And for the second aim, that is within the group evaluation, ANOVA test or the chi-square test was performed amongst all the peers. So this is the chart which helps us get idea about how the methodology was conducted. It is visible. So all live-born kids during that tenure from 2000 to 2007, and whose data could be extracted from Statistics Netherlands and having no severe congenital malformation were included in the study and divided into 2 groups depending upon their gestational age as 25 to 29 weeks of age or 40 weeks, that is term age. And this was the sample size they got. amongst the preterm age group, around 5,777, amongst which around 81%, that is 4,677, survived to discharge. And amongst the term age group, 40 weekers, almost 99.5% survived to discharge. And these were the kids whose data was used for special education analysis at the end of 12 years of age, that is at the end of elementary schooling, based on the data available from academic attainment test. So the test data available in the third row, the test data available for 47.7% of the preterm children, and the test data that was available was almost 62% for the term age group. And amongst these whose data was available, almost they could exactly match the variables along with the figure, like sample size 2231, and these were then included in the research further. So this data, this chart depicts on the left hand side very preterm birth and the control group. If I can move the cursor, I don't know whether everybody is able to see. So this is the very preterm birth and the control group. And we can see over here is all the variables mentioned on the left hand column, right from birth weight, matching and the other variables, sex, parity, maternal age, socioeconomic status, all are matched exactly. And birth weight has got the significant p-value. And on the right hand of this table, the comparison is made amongst the very preterm birth gestational age kids, so as to eliminate all the confounding factors that can come in between the research. This table shows amongst all surviving children in the very preterm birth compared to the control group, the rate of special education in the preterm birth is 10.2%, but compared to the control group, which was only 2.7%, with significant p-value of less than 0.01. And beneath, amongst the very preterm birth and the control group, all the scores on that academic attainment test, if we compare, the standard deviation was significant for very preterm birth compared to the control group, with significant p-value of less than 0.001. Even the lowest line, that is percentage pre-vocational secondary school type advice, was required in almost 61.5% of the very preterm birth kids, compared to the control group, that was 46.4%. So all values were, p-values were significant. Again, in this table also, when the second aim, that is the comparison between the gestational the preterm age group kids, if you can see here, percentage children attending the special education was higher in the 25-weeker born kids, that was 15.3%, and the percentages of requiring the special education help goes on decreasing as the week of gestation goes on increasing. And likewise, all the scores, the total score, language score, mathematics score, and the percentage children with the requiring special education, the similar kind of trend was noticeable. The standard deviation goes on decreasing as the gestational age increases. So academic attainment was assessed using 5 outcome domains, and consistent significant deficit were seen in all 5 measurements. Special schooling rate was about 4 times higher in very preterm children. Very preterm children received 1.3 times more often a pro-vocational secondary school advice comparatively. Within the group of very preterm children, a gradual improvement in academic attainment score was seen with every increasing completed week of gestation. Strength and advantage of this study was the large population-based data sets representing a school-based school setting over multiple years with the exactly matched term control group, and 5 different measures of academic attainment, including special education rate, was utilized. This study provided an invaluable opportunity to determine the impact of prematurity on individual academic outcomes later in life. Instead of study or hospital-based results, it provides population and school-based long-term outcome data for a large sample of very preterm born children. Some pointers about limitation of this study were that approximately two-thirds of the elementary school uses the standard nationwide test, and that was used for a linkage analysis. The test data that was utilized for this research was based on dependent upon the permission of the school, if they are ready to share the individual data of their pupils and the willingness of the school to participate in that academic attainment test. The data on school outcome at 12 years was also not available for many of the preterm born kids. And so that also was the limitation of the study. And as children included in the study were born between year 2000 and 2007, the long-term result of this study may not necessarily be applicable to the current born generation of infants who are born below 30 weeks of gestation. So these 4 points were the limitation of the study. What this study adds to our knowledge is that very preterm children born at 25 and 22 weeks of gestation have significant deficits in several measures of academic attainment at age of 12 compared with their term-born peers. A gradual improvement was seen with every increasing completed week of gestation from 25 to 29 weeks for all the academic outcome measurements. Hence, lowering the threshold for active management of extremely preterm infants results in improved long-term academic outcomes. Scope of further study. This slide is not from the article, but it is my personal thought process that there is a dire need to extract such data, which is population-based, school-based, from the school-based registry of academic attainment for evaluating the long-term outcomes of very preterm children in our own Indian population to determine such correlations. And I feel like in future, if we can conduct such kind of study at 2 different times, that comparative study can be utilized at international level also to help us analyze the improvement in quality of our neonatal services. Actually, this idea, the second point, I could extract because when I searched for such a study on PubMed and other databases, I could not get any of the study from Indian India, but I could get hold on to a study again from Netherlands, which they conducted between somewhere 2011 and 2017. And they used it for comparison. So I got that idea from this study. So this is the scope of further study for us. Thank you all for patient listening. And thank you MahaIP and AHA Raigad and IIP Raigad for giving me this valuable opportunity to share this study. Thank you.
Thank you, Dr. Dinesh. The presentation was really informative and thought-provoking.
Please stop.
Yes, sir.
Yeah.
Now I request Dr. Samir Dalwai sir to comment on this article.
सर्वप्रथम नमस्कार सर्वांना. गुड इव्हनिंग टू रिस्पेक्टेड प्रेसिडेंट सर. माझ्या शेजारीच बसलेत डॉक्टर रमाकांत भाई. आणि वी बिंग ग्रीटिंग्स टू यू फ्रॉम दी होली लँड ऑफ लॉर्ड जगन्नाथ. आणि ही बी मीटिंग इथे. आणि आय कॅन अश्युअर यू आम्ही दोघे मगासपासून फक्त प्युअर पाणीच पितोय. तसं काही कोणाला संशय यायचं काही गरज नाही. आणि ऑल्सो गुड इव्हनिंग अँड रिस्पेक्टेड डॉक्टर माय डिअर फ्रेंड अँड ब्रदर डॉक्टर अमोल पवार भाई, माय डिअर ब्रदर डॉक्टर वसंत खरटकर sir, all the office bearers of Central IIP, my colleagues in Central IIP, my dear friend Dr. Pankaj Deshpande, Dr. Mohanty sir, all the respected seniors, Dr. Jay, who was so kind to introduce me, and all the wonderful people from MahaIP, from AHA, all of you are present today, and of course my dear friend Dr. Dinesh. So thank you so much for giving me this opportunity to sit in on this wonderful presentation by my student at one time and a colleague now, Dr. Dinesh Saroj. आणि मला आठवतंय त्याचा चेहरा 10 वर्षापूर्वी जेव्हा सायनला रेसिडेंट होता. आणि विशेष म्हणजे आजही तसाच चेहरा आहे. त्याचा त्यात काही फरक झालेला नाही, फक्त नॉलेज वाढलेलं आहे. आणि आहे तो तसाच आहे, हसतो वगैरे तसाच होतो. सो थँक्यू सो मच. आणि प्रथम आय वुड लाईक टू से की दिनेश, यू सिलेक्टेड अ गुड टॉपिक. इट इज व्हेरी इम्पॉर्टंट. कारण आपण पीडियाट्रिशियन्स म्हणजे आपण फक्त प्रीटर्म बघतो, त्याचा जीव वाचवावा कसा असं बघतो. विथ लेस मॉर्बिडिटी आपण म्हणतो, म्हणजे there is no paralysis or there is no focal neurological deficit. पण त्याच्यानंतर काय होतं, ह्याला आपण बेसिकली लॉस टू फॉलो, मूल नाही, वी आर लॉस टू फॉलो. आणि म्हणूनच ह्या स्टडी तुम्ही घेतल्यामुळे पीडियाट्रिशियनने, आणि मला अध्यक्ष सरांनी आता सांगितलंय की मराठी इज ऑफिशियल लँग्वेज ऑफ MyIP, म्हणून परत काय परवानगी घ्यायची गरज नाही आणि मी मराठीतच बोलणार आहे. तर म्हणून हा स्टडी तुम्ही सिलेक्ट केला, दॅट इज व्हेरी इम्पॉर्टंट. कारण कमीत कमी आज तुम्ही सर्व आपल्या पीडियाट्रिशियन मित्रांना तुम्ही सेन्सिटाईज केलं की बाबांनो, फक्त तिकडे त्याला व्हेंटिलेटर वगैरे करायचं नाही, त्याच्यानंतर आयुष्यभर पडसाद असतात. तेव्हा हे लक्षात राहिलं पाहिजे. आणि यू प्रेझेंटेड व्हेरी वेल आणि वंडरफुल. आय एम सो प्राऊड ऑफ यू. कीप गुड वर्क दॅट यू आर डुईंग. कमिंग टू द स्टडी, थँक्यू. कमिंग टू द स्टडी, वेस्टर्न वर्ल्ड कडून आपल्याला रिसर्च मध्ये काय शिकलं पाहिजे या स्टडीमधून दिसतं. अशा अवघड टॉपिक पूर्ण देशभर करून त्याच्यातले एवढे डेटा, म्हणजे हजारो मुलांचा डेटा कलेक्ट करणं, त्याची व्यवस्थित स्टडी डिझाईन करणं, स्टडी मेथॉडॉलॉजी करणं आणि ते या एवढ्या उत्कृष्टपणाने पार पाडणं हे सोपं नाही, बरंच अवघड आहे. आणि हे करणं आणि शिकणं आपल्या यंगर स्टुडंट्सना खूप गरजेचं आहे. आय थिंक पंकज ऑल्सो विल टेल यू अ लिटल बिट मोर अबाउट दॅट इन डिटेल. बट आय वॉज व्हेरी हॅपी बिकॉज द मेथॉडॉलॉजी दॅट वी सी फ्रॉम द वेस्ट इज व्हेरी इम्पॉर्टंट and that is what we have to learn and be able to pick up in India in our own setting, and we have to be able to do that. Having said, दोन गोष्टी मला एक सांगायच्या आहे की हे जे रिसर्च स्टडीज जे होतात, आपण पण स्टुडंटना आपण बघतो, त्याच्या आपल्या प्रॅक्टिसवर काय इम्पॅक्ट होतो हे समजणं तेवढंच अवघड असतं. आणि इस्पेशली इन डेव्हलपमेंटल बिहेवियर ऑफ पीडियाट्रिक्स हे खूप अवघड असतं. आणि त्याचं मेन कारण असं आहे की आपण स्टडी बघत असताना मेथडॉलॉजी आपण बघतो, मेथडॉलॉजी या स्टडीमध्ये ब्रिलियंटच होती, पण मेन बघितलं पाहिजे की या स्टडीचा आउटकम आपल्या देशात, आपल्या प्रॅक्टिसमध्ये रेलिव्हेंट कसा आहे. एकच मिनिट, मी एक पीपीटी थोडीशी शॉर्ट मध्ये बनवलंय, मला ही शेअर करता का येत नाही मला. एकच मिनिट, थोडेसे मी जस्ट मुद्दे बनवलेले बिकॉज आय वॉन्टेड अवर पीडियाट्रिशियन्स टू टेक होम दॅट पॉइंट. एकच मिनिट. बर,
Yes, yes,
कॅन यू सी द प्रेझेंटेशन?
yes. Make it a full screen.
आणि म्हणूनच मी जे हा आणि म्हणूनच आपल्याला सर्वांच माहित आहे दॅट एक्स्ट्रीमली प्रीटर्म किती आपण जर मॅनेज केलं सेव्ह लाईफ, बट देर इज अ पोटेन्शियल फॉर सबसिक्वेंट डिसेबिलिटी. आणि अकॅडमिक अटेनमेंट ह्या स्टडीमध्ये द पॅरामीटर दॅट दे हॅव टेकन एज आउटकम इज अकॅडमिक अटेनमेंट बिकॉज इट हॅज सो मेनी इफेक्ट्स. पण मला असं म्हणायचं की डिबेटेबल आहे. ऍक्च्युली व्हॉट डिटर्माइन्स द क्वालिटी ऑफ लाईफ और सक्सेस इन लाईफ, इज इट ओनली अकॅडमिक रिझल्ट्स ऑफ परफॉर्मन्स ॲट स्टँडर्ड 12 as they have taken in this study? So they have assessed academic attainment, but Magashi Dinesh said that many of these are in a special school already. आता स्पेशल स्कूल मध्ये ह्या मुलांना जावं लागेल, ह्याचा अकॅडमिकली खूप काही फायदा होतो आपल्याला कळून असं मला वाटत नाही. आणि त्याने हे पण म्हटलेलं की पोटेन्शियल जेस्टेशनल एज रिलेटेड ग्रेडियंट्स वुड बी इम्पॉर्टंट. तेव्हा जेस्टेशनल एजचा काय फरक पडतो हे आपल्याला माहित आहे. त्याचप्रमाणे बर्थ वेट, मेल फिमेल पॅरिटी, मॅटर्नल एज, अनफॉर्च्युनेटली त्या स्टडीमध्ये हे जे फॅक्टर्स होते ज्याच्या आपल्याला कळू शकेल की मेल चाइल्ड असेल तो याचा हायर रिस्क, असं काही त्या स्टडीमध्ये त्यांनी सांगितलेलं नाही. ऍडव्हान्टेज त्याच्यात त्यांनी म्हटलंय की टू डिटर्मिन द इम्पॅक्ट ऑफ प्रीमॅच्युरिटी ऑन आउटकम्स लेटर इन लाईफ, म्हणून मी आउटकम्स जास्त हे केलंय. कारण अकॅडमिक अचीवमेंट जे आपण म्हणतो, पुअर स्कॉलरशिप, आपण डॉक्टर माधुरी कुलकर्णीचे बरेचसे लेक्चर्स आपण आठवू शकतो. सो अकॅडमिक अचीवमेंट इज नॉट अ स्पेसिफिक फंक्शनल डोमेन. इट इज नॉट लाईक अ सिटिंग or a walking. It's not a perfect milestone. It is actually an uncertain conglomeration and hence it is impacted by many subdomains. म्हणजे academic performance ला cognition किती आहे, मुलाची मेमरी किती आहे, प्रोसेसिंग ऑडिटरी वर्बल प्रोसेसिंग, व्हिज्युअल प्रोसेसिंग स्किल्स किती आहेत, अटेन्शन स्पॅन कसं आहे मुलाचं. आणि हे मी मुद्दामून वाचतोय कारण माझी अपेक्षा आहे की हे आपण लक्षात ठेवावं. मुलाचं मोटिवेशन काय अभ्यासासाठी, मुलाला एन्झायटी असते का अभ्यासाची, आणि त्याहूनही जास्त अकॅडमिक एन्व्हायरमेंट आपण त्याला शाळेत काय प्रोव्हाइड करतोय, टीचर्स किती अंडरस्टँडिंग आहेत, आणि त्याहूनही जास्ती सोशो इकॉनॉमिक फॅक्टर्स ऑफ फॅमिली आणि सोशो कल्चरल. एखाद्याला घरात शिक्षणाचं काही जोर नसेलच तर त्याचा एक दृष्टिकोन वेगळा असेल, आणि खूप जास्त अभ्यासाचं जर प्रेशर असेल त्याचाही दृष्टिकोन वेगळा असेल. ऑल दिस इम्पॅक्ट अकॅडमिक अचिव्हमेंट, नॉट जस्ट बायोलॉजिकल फॅक्टर्स लाईक प्रीटर्म डिलिव्हरी. आणि म्हणून आपण रिसर्च स्टडीज बघत असताना मेथडॉलॉजी जेवढी जरुरी आहे त्याचप्रमाणे आउटकम्स चोजन आपला अंडरस्टँडिंग शेप करत असतात. आता हा स्टडी ऐकल्यावर अरे बाबा असं आहे का, प्रीटर्म असेल तर त्याला अकॅडमिक प्रॉब्लेम होणार आहे आणि म्हणूनच त्याला सुरुवातीपासून ट्युशनला लावा. हा चुकीचा गैरसमज आपल्या मनात येऊ नये, या pediatricians should be focused on, because these studies determine our advice to parents as well as determine our policy towards these children both at individual policy level. नाही प्रीटर्म मूल आहे ना, हे अकॅडमिकली चांगलं करणारच नाही का, कारण प्रीटर्म आहे. अरे बाबा पण हे कुठे आपण बघितले हे फॅक्टर्स, कॉग्निशन कसं आहे, मेमरी कसं आहे, मोटिवेशन कसं आहे, सोशल इकॉनॉमिक स्टॅटस कसं आहे, हे सर्व बघितलं पाहिजे. आणि म्हणूनच लुकिंग ॲट अकॅडमिक परफॉर्मन्स, डोंट लुक ॲट इट बेस्ड ओनली ऑन एक्झाम रिझल्ट, कारण एक्झाम रिझल्ट इज बेस्ड ऑन ऑल दोज फॅक्टर्स. It is not at all a comprehensive developmental assessment or indicator of the sequelae of prematurity. हे आपल्याला लक्षात ठेवायला पाहिजे. पण if research studies are designed to focus on such outcomes, ही स्टडी बरोबर आहे मेथोडॉलॉजिकली, पण दॅट परपेच्युएट्स द फॅक्ट अरे बाबा प्रीटर्म म्हणजे तो अभ्यासात व्यवस्थित होणार नाही, त्याला स्पेशल शाळेत पाठवा. हे एक आपण म्हणजे पत्थर की लकीर धरतो, त्याच्याबद्दल जरा आपण अवेअर राहिलं पाहिजे. कारण इन रियालिटी द डेव्हलपमेंटल डोमेन्स of सामाजिक social interaction, social behavior, social orientation, social independence as well as communication are far more important in a child's ultimate outcome, and hence it is far more important to critically appraise what determinants are being viewed as outcomes. कदाचित नेफ्रॉलॉजी मध्ये पंकज सर आपल्याला सांगतीलच. आता युटीआय म्हटल्यावर आपल्याला सेल्स बघता येतात किंवा केमिकल पॅरामीटर्स बघता येतात, ते स्ट्रेट फॉरवर्ड आहेत, पण ह्याच्यात ते स्ट्रेट फॉरवर्ड नाहीत. आणि म्हणूनच पीडियाट्रिशियन्सना माझा टेक होम मेसेज असा राहील की when we look at research, we need to appreciate that sequelae in preterm children need to be studied developmentally, not academically. While viewing especially a foreign study, त्यांच्या जे आउटकम्स त्यांना जे इम्पॉर्टंट आहेत आणि आपल्या समाजात जे आउटकम्स आहेत हे खूप ह्याच्यात खूप फरक असू शकतो, इस्पेशली इन डेव्हलपमेंट बिहेवियर पीडियाट्रिक्स. आणि म्हणूनच मी शेवटी एवढंच सांगेन की आपली जी काही प्रीमॅच्युअर मुलं असतील किंवा लो बर्थ वेट मुलं असतील आणि आपण डेव्हलपमेंटल असेसमेंटच्या बद्दल आपला विचार असेल पीडियाट्रिशियनचा, आपल्याला 2-4 मिनिटं मिळणार आहे. एक मेसेज जर त्या मुलाला आई वडिलांना द्यायचा असेल तर तुम्ही अकॅडमिक मेसेज दिल्यावर ते आयुष्यभर बिचारे ट्युशन, ओटी, स्पीच थेरपी, रेमेडियल एज्युकेशन, स्पेशल एज्युकेशन, ही शाळा ती शाळा हे करत बसतात. त्याच्यापेक्षा जर माझं म्हणजे ह्याचं काय माझं काही रिसर्च पब्लिश नाहीये, पण जर मला सांगायचं असेल, मला जर तुम्ही अपॉर्च्युनिटी, मी एक सांगेन की तुमच्या मुलाला काकी, मामी, मावशी आणि आत्या या 4 स्त्रिया जगात खूप इम्पॉर्टंट आहेत. प्रत्येकाला काकी, मावशी, आत्या आणि मामी या 4ही बायका रिलेटेड नाही आहेत बरं, ते वेगवेगळ्या घरातून येतात. प्रत्येक स्त्री आपलं घर वेगळं चालवते. तेव्हा तुमच्या काकी, मामी, मावशी आणि आत्या यांच्या घरी जाऊन एकटं 2 दिवस आई शिवाय राहता येतं का, हा आपला आउटकम डिटर्मिनेट असला पाहिजे. आणि कृपया पुढच्या वेळी दिनेशला मी रिक्वेस्ट करेन की असा एक स्टडी घडवून घ्या, किंवा रमाकांत भाईकडे बसलेत, ऑल महाराष्ट्र आपण मल्टी सेंट्रिक बसून हा स्टडी घेऊया की ज्या मुलांना डेव्हलपमेंटल बिहेवियर प्रॉब्लेम आहे त्याला 12 वर्षात मार्क किती गणितात मिळाले किंवा नाही मिळाले ह्याच्यावर डोकंफोडी करण्यापेक्षा तो मामी, मावशी, आत्या, नानी, आजी यांच्याकडे जाऊन समाजात आई शिवाय एकटा असतो का 2 दिवस, हे केलं तर त्या मुलाचा इंडिपेंडन्सचा सोडा ती आई इंडिपेंडेंट होईल. आणि मला वाटतं आपण असे आउटकम विचार केले पाहिजे. थँक्यू सो मच दिनेश, वंडरफुल, वेल डन. थँक्यू.
थँक्यू सर.
थँक्यू सर. सरांनी आपल्याला अगदी प्रॅक्टिकल टिप्स ऍक्च्युली दिलेल्या आहेत अँड जनरल पिडियाट्रिशियननी काय काय लक्षात ठेवायला पाहिजे हे सगळं आज सरांनी सांगितलेलं आहे. अँड सर विल बी डेफिनेटली रिमेंबरिंग ऑल दिस पॉइंट्स. सो नाव आय रिक्वेस्ट we just go on the second topic today, and I request our Raigad IIP President Dr. Vikas More to introduce our dynamic expert Dr. Pankaj Deshpande and our second speaker Dr. Parvez.
Yeah, Dr. Vikas sir. Dr. Vikas. Okay, we will go ahead. Dr. Pankaj Deshpande, very, very talented consultant pediatric nephrologist, and he's working in Mumbai and Navi Mumbai. And he is very keen to pass on the knowledge of his expertise to our pediatricians. Our presenter for topic extensive review article of UTI is our Raigad IIPN EB member and practicing pediatrician at Alibag, Dr. Parvez Sheikh. And he is academically oriented right from beginning. Over to you, Dr. Parvez.
Thank you, madam. Is my screen visible, madam?
Yeah. Make it full screen.
Yeah, at the onset, I'd like to thank MAHA-IP and IP Raigad for giving me this opportunity. And special thanks to Mohanty sir and you for guiding me for this article. Basically, this is a review article. It's a urinary tract infection in children. It was published in Pediatric Clinics of North America. And in this article, they have reviewed various international guidelines and their implication. So what we already know, UTI is a comorbidity problem, and we all are managing it on a day-to-day basis. What this article revisit our known knowledge about UTI management and gives us new insight about diagnosis and management. So in UTI is a common in children. Around 1.7% of boys and 8.4% of girls before the age of 7 years get affected by UTI. So the main concern in management of UTI is preservation and protection of the kidney function and the kidney growth. This review articles compares and summarizes major international guidelines to manage UTI in pediatric age group. So for diagnosis in older children, it is straightforward. They have a urinary complaints, flank pain with fever, urgency, frequency, incontinence, or a dysuria. But in a younger child, symptoms are often non-specific. Vague, fever, inadequate feeding, or lethargy or failure to thrive can be presenting symptoms. For that, there are various algorithms which can make UTI more likely and can guide clinicians when to suspect UTI. As far as the sampling is concerned, the non-tolerate trained babies, the best results are obtained by the invasive methods, of which suprapubic aspiration is the best. Second choice is catheterized sample. Of course, it can be debated, but in non-invasive way, midstream urine, it's widely used as it is convenient. Adhesive bags or nappy pads have high rate of contamination and should be discouraged. Then we come to urine biomarkers. The most simplest test is leukocyturia by simple microscopy, which is widely available at periphery also. And it's a strong indication of bacteria, sensitivity of 83% and specificity of 78%. There is other tests like urine nitrate, which has low sensitivity of 23% in infants, as they have a shorter voiding time and the dietary intake of nitrate is less. Then there are new promising methods, neutrophil gelatinase associated lipocalin and interleukin 8. These are highly sensitive and specific in differentiating UTI from other febrile illness in children. Looks promising, but we'll have to revisit in our own context. Then the gold standard for diagnosis is urine culture. The growth of single strain of uropathogenic bacteria is indicative of UTI. The significant growth traditionally was defined as 1 lakh CFU per ml. Infant with shorter voiding intervals can have a lower bacterial counts in symptomatic UTI. That can be kept in mind, especially when caused by bacteria other than E. coli. And as we all know, culture takes time to, reports take times to come. So we have other newer genetic methods like PCR and other genetic tests where we can test for identifying organism, virulence, resistance, and various other parameters, provided it is the availability of this test. Then treatment, empirical antibiotic as per the antibiotic resistance profile of community, and again depends on the availability of drug which is suitable for children. Then oral is preferred, but in less than 2 months of age, IV is preferred route of treatment. Usually third generation of cephalosporin are the drug of choice. Other alternatives include amoxicillin, clavulinate, and other antibiotics. There is various debates on duration of treatment, but most of them consensus is around 10 days with a span from 7 to 14 days, which depends on severity of infection in the children and the age of the children. For cystitis in children above 2 to 3 years of age, where kidney involvement can be ruled out, most guidelines recommend 5 days of antibiotics. Then there is one entity called as asymptomatic bacteriuria. This is considered as a partnership between bacteria and the host, which protecting against symptomatic UTI in the susceptible individuals, and it is best left untreated. Then what about prophylaxis? So prophylaxis is widely practiced, but now it has declined substantially after proof of only moderate or no effect on the rate of recurrent UTI in several studies, with exception of young girls with dilated VUR. So however, in selected patients who are carefully followed and carefully selected, prophylaxis can help them from protect them from recurrent UTIs. Evaluation of the urinary tract infection. So the evaluation after UTI is done to detect underlying congenital anomalies, as various congenital anomalies are diagnosed as per the first UTI in the early age of life, then kidney damage and bladder dysfunction. Of course, the ultrasound is widely available and is a primary investigation to be considered after first time UTI in infant and after febrile UTI in older children. So we have two approach over here. Either we can go top-down approach or a bottoms-up approach. Top-down approach is nothing but we evaluate kidney first, followed by the bladder and VUR assessment, where the focus is on the preservation of the kidney function. It relies on the fact that VUR of any significance is usually associated with kidney involvement at the time of febrile UTI. So we do DMSA scan, can identify kidney involvement in acute phase of infection. However, to capture all acute parenchymal involvement, it has to be done shortly after starting of treatment. In a bottoms-up approach, we evaluate first vesicourethral reflux by voiding cystourethropy, and then it is gold standard to diagnose grading of VUR and posterior urethral walls. So by this, we are restricting VUR assessment by VCOG if DMSA is abnormal or there is a dilatation of upper urinary tract on ultrasound. This will reduce the number of VCOG substantially, as it involves catheterization and a radiation risk, and there is a small risk of UTI. So there were various guidelines in this article. So I have just shortlisted upper two, which is US and the UK guidelines, and I have discussed that in these next two slides. But there are various others also. So in US guidelines, they have focused on 2 to 24 months, and they have recommended urine collection in non-toiletry individuals. First is catheterized or suprapubic aspiration, and second is midstream urine for screening. And they have defined as the significant bacteria level as 5:10⁴ colonies per deciliter. Blood test, they have recommended no blood test to be done to diagnose UTI or to prognosticate UTI. Route of administration in febrile UTI, IV if baby is toxic or unable to retain oral liquid. The length of treatment in febrile UTI is 7 to 14 days as per the AAP guidelines. Prophylactic antibiotic they have not recommended. Ultrasound in all children. Voiding cystourethrogram, if abnormal ultrasound or a complicated UTI, then consider, or if there is a recurrence, then consider. They have not mentioned DMSA to be done routinely. Then UK NICE guidelines, they have included children of 0 to 16 years. Urine collection in non-toiletry individuals, first choice is midstream urine, second is pad, and third is catheterized or suprapubic aspiration. So here they differ in approach. Then significant bacteriuria, they have not defined any level for significant bacteriuria. Blood test recommended CRP should not be used to differentiate upper or a lower UTI. Then route of administration in febrile UTI, less than 1 month is IV, 3 months and toxic, again IV, more than 3 months, usually oral. The length of treatment, febrile UTI has to be given for 10 days. Prophylactic antibiotics not recommended. Ultrasound, less than 6 months should be done in all children. More than 6 months, if it is atypical or a recurrent UTI, then we have to do. VCUG less than 6 months if atypical UTI or a recurrence, and 6 to 36 months consider if it is atypical or a recurrence with risk factors. So what are the risk factors? If there is a dilatation on ultrasound, poor urinary flow, or a non-E. coli UTI and a family history of EUR. They have recommended DMSA to be done in less than 3 years if atypical or a recurrent, or if more than 3 years if recurrent UTI. Then one important factor of UTI is always concentrate on a bladder and a bowel dysfunction, because children with functional disorders of bowel and or bladder, including bladder instability, constipation, infrequent voiding, have an increased UTI frequency. So constipation should be assessed and treated in children of all ages. Assessment of incomplete bladder emptying should be done in children suspected of having bladder dysfunction. So what are the risk factors for kidney damage? It is important to identify children at risk of recurrent UTI and kidney damage. One of them is high-grade VUR, increased inflammatory markers such as CRP is more than 70 or a poor calcitonin is 0.5 to 1. Then delay in the administrative treatment and a non-E. coli UTI. Plus there are some rare causes of innate immune dysmorphism which have a dysfunction immune system and can have a recurrent UTIs. What are the long-term outcome of urinary tract infection? So risk of permanent kidney damage after febrile UTI during childhood has been reported as 15%. Though the population-based data, long-term data are available only from Sweden and Finland. So they have compared around 1200 children with UTI and they have followed up carefully till almost 40 years of age. And they found that risk of progressive kidney disease and hypertension is very low in children with UTI in childhood, provided they are managed properly. So what are the perspectives of future? Introduction of new biomarkers like NGAL and interleukin-8 may allow rapid and safe diagnosis of UTI. Alternative diagnostic tool to replace urine culture are emerging like genetic tests, PCR and other genetic tests. More studies are needed on commensal microbiome of intestine and urinary tract, how these are affected by antibiotic treatment, and their role in natural defense against UTI. So what are the take-home messages? Urinary tract infection can be initial manifestation of congenital anomalies of kidney and urinary tract. Infant with fever of unknown origin should be screened for UTI. Set urine culture before starting antibiotic treatment when UTI is suspected. Do not use bag or nappy pad urine for culture. 1 of 5 infants with symptomatic UTI have urine bacterial count less than 10⁵, regardless of sampling technique. So oral antibiotics are safe and effective for treating febrile UTI in children about 2 to 3 months of age. Avoid antibiotic treatment in children with asymptomatic bacteriuria. Non-E. coli UTI should raise the suspicion of urinary tract anomalies. Thank you.
Thank you, Dr. Parvez. It was indeed an insightful presentation, excellent, clear, and an understandable one. And sir has also discussed all the details like symptoms of various age groups, biomarkers, approach to UTI, and all the points were very well discussed. Now I request Dr. Pankaj to comment on this topic.
Right. Can you hear me?
Yes,
I think I would just like to point out in the previous study of the developmental anomalies, if they had done creatinine and protein creatinine ratio, that would have been far more valuable than looking at the developmental criteria, but forget that part. Now this paper, Dr. Parvez has presented it very well. Whatever is there in the paper, whatever data is there, he has presented it extremely well. So I must congratulate Dr. Parvez for that.
Thank you, sir.
But coming back to the actual paper itself, does it really add to our knowledge or confuse us is the bigger question. If I take a vote of whether everybody is now clear on what to do or confused about what to do, I think the answer is that everybody will be more confused. Because let's start off with the very basics. I mean, this was a paper done in Sweden. The environment in Sweden is entirely different to what is there in our country. And therefore, we cannot apply. For example, you're talking of suprapubic aspirate. Suprapubic aspirate, we're not going to be doing in our OPD practice. So it's one of the bigger problems that is there, that when we look at these kind of studies, yes, they may work very well in places where there is a home nurse who goes and does these kind of things. It's not going to happen in India. So there is a big fallacy. And unfortunately, this is the paper that gets quoted everywhere, saying that this is the paper that said this, and therefore we should be doing it. So that's one of the problems, how much it is applicable to India. There are several factors there that cannot be applied in India. The second important fact of a paper, any journal that you have, any review that is done, at the end of it, there should be some guidelines for us to follow, which makes it easy. As Samir was saying, how applicable is it to us to change our practice? Now, yes, we got a lot of data from there, but what we found is, and thank you for putting only 2 of the guidelines there, US, because as you know, the paper has got 9 or 10.
Yes,
and
sir.
if you actually analyze the data from these different geographical locations, the Asian guidelines have come from Japan. which is completely different to India. So that those guidelines don't apply to us. If you look at Indian guidelines, they're completely different to what has been given in your presentation, because we are talking about completely different scenarios in Indian conditions. So unfortunately, the paper falls very short of giving a very simple practical message at the end. It is reiterating the fact what we know. We know that urine infections are important. We know the practical problems that we face. For example, we face problems of how to diagnose a urine infection. It is not a question of how to treat. Treatment is the easy part. Diagnosis of urine infection is the biggest problem. And therefore, urine collection becomes very important. The factor that goes into diagnosis of a urine infection is a symptomatic child. And I think there should have been more elaboration. You mentioned, and there is a passing reference in the paper, about algorithms used to decide who to do a urine sample in. Unfortunately, they have not clarified it, because these algorithms are important for our practical purposes as to who do we send a urine sample in. For example, every child who comes to the OPD with a fever, do you send a urine sample? No, you don't. If you have a focus of fever, do you send a urine sample? No. If the child has 24 hours fever, do we send a urine sample? We don't know. Or is it for 72 hours? So just while I'm talking, whoever is attending Mahapedicon, please come and listen to what I'm going to talk about this, because Indian research is required, and that's what I'm going to be talking about there. What is practical in our OPDs and what can be done. So I think it's on Friday. So these are the factors that would have been made more sense to delve into, because we need to know where to send a urine sample, when to send a urine sample, and then how to interpret it. So it's very easy to say that leukocyturia is present, but we also know that leukocytes are present in other conditions, which they haven't mentioned at all. I mean, I find it very surprising that they haven't mentioned that pyuria is not a diagnostic of a urine infection. Now, when they talk of sensitivity, please tell me when to stop, because I can keep on talking. So, if you talk of leukocyturia, significant pyuria which is present, and then they talk of sensitivity and specificity, please understand that the sensitivity and specificity studies came about when they looked at urine cultures. Now, is urine culture itself diagnostic of a urine infection? Nobody knows. Because if you have an asymptomatic child and a child has a positive urine culture, that's not necessarily a urine infection. So this has to be taken with a pinch of salt. So when they talk about these figures of 99% specificity and 83% sensitivity, we need to be careful about what they are trying to say. So for our practical purposes, the presence of leukocytes in the urine should make us think of a urine infection, but we should remember that it is not diagnostic of a urine infection. So it may prompt us to send a urine culture if the child has symptoms that suggest a urine infection, not necessarily just seeing the pus cells. For example, a child presenting with a cough and a cold is going to have 15 to 20 pus cells in the urine. That is not a urine infection. A child who's got appendicitis has 100 pus cells in the urine. That's not a urine infection. So this is what needed to be clarified far more there, rather than everybody focuses on investigations rather than the actual diagnosis of urine infections. And unfortunately, the paper falls short there. What they have done is they've just collected all the guidelines all over the world, and they've just published it and commented that this is what various guidelines are saying. Even when you talk about the investigation part, now the top-down approach and the bottoms-up approach, which they have talked about. Now, when you say top-down, understand that they're talking of an acute DMSA. How many amongst us have done an acute DMSA? None of us have done. Because when you do an acute DMSA, you have to repeat it again in 6 months' time. So the child is not only subjected to radiation, but its expenses. So you are making a child undergo the same test twice to determine whether you want to do further tests. It doesn't make sense. So Indian guidelines are different from that, because we are approaching that from the perspective of how practical it is to apply to the Indian population who presents with a urine infection. The second categorical statement which they seem to have made is a child more than 2 to 3 years of age with cystitis can be diagnosed fairly easily. I challenge them. I challenge them to diagnose the child who's 2 to 3 years of age who has fever and pyuria and now say that he's got only cystitis or he's got pyelonephritis as well. It is impossible to make out. So unless you're talking of an older child, 8 years, 9 years, 10 years, it's very difficult to distinguish between an upper UTI and a lower UTI. So it's very difficult to recommend tests based on that. Now, even in the two guidelines that you have put up there, the UK guidelines are completely different to the US guidelines. And therefore, we need to still follow our Indian guidelines. The next part is about prophylaxis. Now, prophylaxis, they say it works. They themselves in the review are not clear of what they want to say, because the Swedish trial showed that it benefits, whereas the River trial actually said that there is no benefit of prophylaxis. So they don't know which way to go because they are at a dilemma. So I think for practical purposes, what I say is you need to use prophylaxis where you suspect the child is going to get another UTI. And when do you suspect that? You suspect that when the child has bowel bladder dysfunction. So till that is sorted, you need to use prophylaxis. Now, again, in prophylaxis, they have not cleared up how long you give it for, because our Indian guidelines say long time prophylaxis for high-grade VUR, which is no longer the trend. It's no longer used. I'm very surprised at the categorical statement that VUR, high-grade VUR, is a risk factor for kidney damage, because they have not used a single term of renal dysplasia. A child who gets a single urinary tract infection, has a DMSA done 6 months later, showing a damaged kidney. It's not because of reflux or UTI. It's just that he was born with the dysplastic kidney, which is why I said that for preterm children, if they do creatinines, that would be far more useful than looking at the academic intelligence. Because a lot of children get born with dysplastic kidneys and we are missing them right, left, and center. And we keep on saying that it's reflux and urine infections that keep on causing the damage. They have not addressed that issue at all in the paper. So when you do repeated DMSA scans in children who have got urine infections, and as they say, they've used the word scarring everywhere. They've not used the word dysplasia at all. So when you repeat the DMSA scan 5 years later in a child who's got a damaged kidney, the damage is going to be more, not because the child has had further infections or because reflux is damaging, but because the child is growing. And therefore, that kidney is going to have lesser function as compared to the other kidney, which is normal. This is natural progression. So unfortunately, that distinction has not been made in terms of VUR. Now, there is going to be a paper that is coming out. Again, this is Indian, our own data from Raigad and India. Hopefully in the next 6 months, you'll get that paper out about reflux and long-term outcome of children who have damage also. And it clearly shows there is no risk of recurrent UTIs. Now, all those who say that high-grade VUR is a risk factor for damage, if you put your hand up, then my next question to you is, are you ready to do MCU in every newborn child who's born? Are you ready? Why not? If you are saying high-grade VUR is a risk factor for kidney damage, shouldn't we prevent it there? Because you do not get dilatation in high-grade VUR also. Because the ureters are so flexible, you can have grade 5 VUR and no dilatation on ultrasound. But nobody in the world will agree to do an MCU in every newborn child. That itself tells you the story that it's not a major risk factor. The last part of the study, which was again asymptomatic bacteriuria, has been included in UTI, which I find very surprising. It is a completely separate category. You shouldn't be calling it a UTI. They said UTI presents in 3 different ways. And the only important message about the asymptomatic bacteriuria that all of us need to remember is it is present in a fair number of children, because it was presumed to be present only in adult females. No, it's present in children and infants. Secondly, if you have put a urinary catheter, there is a stent present or any foreign body, you get asymptomatic bacteriuria. So think 100 times before you diagnose a urine infection in such patients, because you will get asymptomatic bacteria because of the film that is formed by the plastic. And the last part, the long-term outcome, many studies have shown that a single UTI in normal kidneys does not cause long-term effects. 15% rate was an old one. And when they look at long-term studies, you need to remember that there are confounding factors that start coming in. A follow-up which is 20 years, 25 years, 40 years. Now, unless you have differentiated between a dysplastic kidney, unless you have looked at the confounding factors like hypertension, which would have set in the patient without there being kidney damage also, it's very difficult to predict what the long-term outcome is going to be. But in general, yes, it is believed that long-term outcome for children who have had 1 or 2 UTIs is not necessarily bad. We shouldn't be missing UTIs, but we shouldn't be over-diagnosing UTIs also. I think that's the message that needs to be taken up.
Thank you, Dr. Pankaj, for your enlightening thoughts and also sharing your experiences. Now I request our guide and mentor, Dr. Naiman Mohanty sir, to share his comments on both the articles.
No, I have no comments now because we had fortunately 2 stalwarts with us. They have threadbare the issues very nicely for the benefit of everybody. In the first topic, the aim was actually not to do it in developmental screening. So the aim was only the intellectual part, or rather the cognitive developmental part only. So they have not done it, and such developmental studies we can attempt in our own setup, maybe collaborating with each other. This is an easy task to do, and it will long-term follow-up is very, very useful. But UTI, Dr. Pankaj is very much right. This topic is taken from PCNA. Naturally, it is from the Western countries, and there they have a mention of the recommendation from the Asian countries. Only club together all the countries, so that may not be fair for us. So we'll look for the papers from the Indian guidelines in that. Actually, in the journal club, he is not supposed to refer outside this paper. He has done very well. And the whatever required was this Dr. Our nephrologist friend, he has clarified for the benefit of everybody. He has it's a compliment to the paper today. Thank you, Doctor.
Thank you, sir. Now I request Dr. Jay Bhandarkar sir or Dr. Pallavi to take some questions, if any, from the chat box.
Ma'am, no.
No questions.
No questions at YouTube, ma'am.
So all doubts are cleared.
एक तर सगळंच समजलं नाही तर काहीच समजलं नाही. त्या दोन्हीपैकी कुठलं आहे ते each one can decide.
91 participants, no question. How this can...
Jay sir will ask one question. Please.
Okay, please complete. Yeah.
And I have always have a doubt how to diagnose UTI, right? But I think though there is Dr. Deshpande sir said that yes, it is a clear doubt or increase more confusion. But I can say from taken messages, 1 in 5 patient will not have more than 10,000 coliform units in the culture. That is the one thing. And very important another take-home message is suppose you got in culture other than E. coli, then you should suspect the developmental anomalies in the patient. So these are the very important take-home messages, I think, from the presentation. And though this article was taken from the PCNA and it was a study taken from the Sweden other than India, but to brought this to notice of the other presentation or audience is also very, very important, because you should then start off thinking about the Indian perspective. And I always admire Pankaj Deshpande. He should look out of box, like, think of UTIs, see local hygiene, vaginal synecdoche, constipation, toilet training, then pelvic muscle dysfunctions. These things are very, very, very important when you think about the UTI infection. And I don't have any question, but I always have a question in the mind whether some patient came with a history of PO or undiagnosed or pure with unlocalized, whether it's an UTI. But definitely, you should always give a thought for that. And we try to do almost a culture of each and every patient, not visa, what is it? Vitrinous histogram, right? Each and every patient, but try to do culture in at least significant of patient when you suspect UTI in that, and not only urine, this routine examination, always say suppose the urine is properly collected, then always you go for urine culture with that also. But take in consideration in which circumstances was collected, and as well as with symptoms, patient was presented, and he must have the clinical correlation with all investigation you do for the urinary infection. That's it.
Thank you, Dr. Jay. Before I invite our Raigad IIP Secretary, Dr. Ajay Kohli, my deepest gratitude to our guide, Dr. Mohanty sir, and our dear Chitra madam for their consistent efforts for our journal journey. And because of them, our journey is becoming smooth and wonderful and happy every month. My thanks to both the experts, guest of honor, for sharing their valuable insights. I'm grateful to both the presenters for their time they spent in careful preparation. Last but not the least, I thank all the viewers for sparing their valuable time and attention. As it is said, active listening helps show empathy and respect by validating the speaker's message. I look forward to see you all in our next journal journey next month. Thank you. And now I request Dr. Ajay Kohli to give the formal vote of thanks.
Dr. Swati has already given the vote of thanks. To mention a few, I'm really grateful for carrying forward this journal journey by Maha-IIP and Dr. Ramakant Patil sir, as well as Dr. Amol Pawar, with our Raigad IIP team and Women Committee Co-Chair, Dr. Neha, who is giving unconditional support. Also, our coordinator, Dr. Jay Bhandarkar and Vikas More, along with Pallavi ma'am, for this smooth operation of journal journey. Thank you very much.
Thank you.